Hey, it's me, Jen again, and today we're talking to the first thyroid RFA provider in the state of Missouri. We'll be joined by Dr. Jason Showmaker after this. Dr. Showmaker is a thyroid-focused ENT physician based out of Merriam, Missouri. I had the pleasure of meeting Dr. Showmaker earlier this year in Fort Lauderdale at an RFA physician training program. Since then, he has implemented this procedure into his practice and is helping save thyroids from surgery. We'll be talking about that, as well as discussing the process of thyroid biopsies for patients with thyroid nodules. Let's meet Dr. Showmaker. Let's talk about your background. You're an ENT. One of the things I was reading about you on your website that I just loved was the reason you went into ENT, that you like seeing patients from 2 days old to 100 years plus, and that most of the problems that you get to fix are simple fixes, but they have a very big impact on the patient's quality of life. And I just thought, that really connects to this whole idea of RFA as well, how you're taking a thyroid nodule and just simply taking care of it rather than having to do surgery on the patient.
From little babies who need help with tongue ties or tubes, tonsillectomy, all the way up to our much older patients who just need ear cleanings on a delicate ear. I love doing all of it. I think the idea of non-surgically treating thyroid nodules is fascinating to me. A huge portion of my practice is thyroid surgery. I love the idea of being able to be comprehensive in what I offer as far as workup and treatment. And I know many patients who are at home and seem to have a nodule that they're worried about, but also worried about surgery. And so the idea to take that worry and thought off their mind with a non-surgical option is really compelling, because I feel like there are many folks with that struggle. Is it worth surgery for what's likely benign or not? And so that's my interest there for sure.
Exactly. I am so excited that we have options now besides surgery for thyroid nodules, considering the fact that most of them are benign and don't really need to be surgically removed unless they just become so large that the patient can't breathe or swallow well, which unfortunately is what happened to me. And it happens to lots of patients, but we have some options now. So let's talk about how your background as an ENT sets you up for success in doing RFAs. I read that you have the ECNU certification. Tell us a little bit about that.
So that certification stands for Endocrine Certification in Neck Ultrasound. It's a multi-year process performing ultrasounds, and it has different criteria for enrollment, but it takes several years and requires passing some tests and fairly extensive review process of your prior work. And so that's, I think, something that I sought out initially as a way to help reassure patients and also to make sure that I was providing the best level of care possible. As an ENT, I spent 5 years training in surgery of the head and neck. And for many ENTs, we do ears, nose, and throat, right? So we do septoplasty and tonsillectomy and sinus surgery and thyroid surgery. In my specific training program, we had a very high volume of thyroid cancers, and we did clinic with endocrinologists at the same time. Many patients will see an endocrinologist and then be referred to a surgeon or not. And in training, we were right there together. The endocrinologist would come in, and then I would come in, and then vice versa. And so we were always talking about patients and always talking about what's the best route and what are our options. And it just made me love treating thyroid nodules and parathyroid tumors as well. So I think I have a pretty extensive background because I worked so closely with endocrinology that it really, really drove me into this alternate route that many have not taken as far as general surgeons or ENT surgeons as with regards to treating and evaluating thyroid nodules. Since that time, a large portion of my practice has become management of thyroid and parathyroid disorders. I'm a high volume surgeon, which means I do a lot more thyroid and parathyroid surgery than most folks. An average ENT probably does between 10 and 15 endocrine surgeries a year. That means thyroid and parathyroid. Don't quote me on the numbers, it's been a while, but I probably do somewhere between 150 and 200 cases a year. And a lot of that comes by virtue of doing ultrasounds, talking with endocrinologists, speaking that same language and being on their level, and then earning their trust with their patients, which is my angle at it, is being this trusted go-to between the endocrinologist and patients. Not everyone who comes into my office is going to have surgery. I'm going to talk to them about all the options and let them know the real risks and values of surgery and what nodules are we comfortable monitoring and what are we not. I think that has been a real passion of mine, is just trying to fill some gaps, that patients have.
I think it's great, that you have such a focus on thyroid surgery. It's important for patients who do have to undergo thyroid surgery that they seek out a surgeon who's got that really strong background in thyroid, because I've heard some bad stories from patients who went to, general surgeons who maybe weren't as experienced in dealing with the thyroid, and then they suffered some, unfortunate complications from that.
A lot of patients take their time getting into, a surgeon's office in the first place, and then quickly have to establish rapport with a surgeon and then trust them to operate on them in a quick visit. And so what I do, is fairly comprehensive, I like to think. I manage patients from the get-go. If their primary care physician feels a nodule, I do my own ultrasound, determine if this is a nodule that needs a biopsy or not, and then do the biopsy the same day if the patient's game for it, and another day if they want to think about it for a little bit. I have the ability to do the biopsy under sedation if we really want to, but that's infrequent. And I have a result for them within 4 days. So wow. A lot of my patients I see on a Monday, and I'm doing a phone call with them on Friday to say, great news, this is not cancerous, or hey, it is, but here's our plan to get it out and treat it. And as an ENT and a surgeon, we leave a lot of time available in our schedules for acute problems, abscesses, trauma, cancers all the time. So we don't have a large volume of chronic conditions like endocrinologists do. So getting in with an endocrinologist may take 2 to 3 months sometimes. Or I'm a week, and that's on purpose. Within a week, we can see you and do the biopsy, and 3 or 4 days later have an answer for what's our follow-up plan or what's our treatment plan for this nodule. I try to be fully comprehensive with folks and get them to their destination a lot faster and with one team, as opposed to, seeing your primary care and going to a radiologist at the hospital for an ultrasound and then waiting a couple months maybe to see endocrinology, and then they'll order a biopsy that takes a few weeks, and then they'll refer you to an ENT, which may take, a couple more weeks. The time gap shortens dramatically, probably from 2 to 3 months down to 2 weeks.
Yes, and that can decrease a patient's anxiety tremendously.
That's right. So endocrinologists and surgeons we know that most thyroid nodules are non-cancerous, right?
Right.
So when we see thyroid mass on the schedule, we say, okay, that's fine, just fit them in. But that disregards the patient not knowing that, and so the patient's at home lying in bed thinking about this growth that they have, and they don't have any information. And for 3 months, they're worried about it.
Yes.
And so if we can get in and evaluate it, I can talk to you about family history and risk factors, do my exam. I provide a lot of reassurance at the first follow-up. And I reassure people that most of these thyroid nodules we do not have to remove if we can prove that it's non-cancerous, by other means. We really cut down on anxiety a lot with that in mind.
Yeah, the process that you just outlined of going to the primary care, being sent to the radiologist, being sent to the biopsy, and the time that takes to complete that whole process does cause a tremendous amount of anxiety for patients. And I see that in our group all the time. We try to guide them through that process and help them, reassure them and help them understand, it takes time, but, at the end of this, you're most likely going to end up with good news. And even if you don't, there are alternatives that, are not as mainstream, like active surveillance, even RFA in some cases, that are available if you can seek those out. So, we try to reassure them throughout this process. It's not a death sentence. It's more of a nuisance than anything.
That's absolutely right. Most thyroid cancers present or are detected early enough that, treatment is very effective. It's quite uncommon for people to have a truly metastatic and incurable thyroid carcinoma at the outset. A lot of our conversation is reassurance, counseling, and guidance, truly. Some people aren't comfortable until it's out. They want it gone. They don't want to see it. They don't want to feel it anymore. And some people, I think, would be equally comfortable if they know that the nodule was dead by other means, that it was killed or ablated and vaporized. So I think that same benefit, that I have many patients who just want it out and they want surgery to get it gone. I think some of those patients will be very pleased with that RFA option. Not have hypothyroidism and not have a scar, not have maybe some temporary voice issues after surgery they have to work through, which are frankly uncommon. But all those concerns weigh heavily on the minds of, patients who are moms and dads of young
Right.
families, and they have their kids to worry about. And many young women worry about their 4-year-old coming and jumping in their lap right after a thyroid surgery, and
Absolutely.
who wants to tell their toddler, like, no, don't come to me right now? I mean, there's so many aspects of it that you can take away with RFA that I find it very compelling.
In your practice, having that fast track going from, from discovery to diagnosis to treatment is absolutely something patients are very interested in. And as we said, to reduce their anxieties and get them to a place where they aren't thinking about this anymore and they're moving on with their life. So
That's right.
that is very cool. Let's talk some about biopsies. And this is another source of anxiety for patients is, they don't know what the biopsy process is. They don't know what the biopsy results mean, and they don't know where the biopsy will lead. So can we maybe go through like a step-by-step, just
Sure.
a kind of a primer on biopsies for patients?
Absolutely. So we do the biopsies at the initial visit if they're interested, and I would say about 95% are, for the exact reason you just mentioned. They want to know, or they might have driven a ways to see me and they don't want to drive again if possible. But largely it's wanting an answer. A thyroid nodule biopsy is done with ultrasound guidance in the office. The exam chair is reclined a bit, so it's like you're laying back. We put a towel down to protect your shirt from ultrasound jelly. It's nice to wear an open shirt just for access. We use the ultrasound to locate the nodule, and then I do inject a local anesthetic onto the thyroid capsule, the muscle, the soft tissue layer, and then all the way up to the skin as we withdraw the needle. The injection, I believe, is typically the hardest part, which is a minor pain, maybe a 2 out of 10 that lasts just a moment. The idea is to inject the needle track so that you don't feel the subsequent biopsies, and many patients don't feel the biopsies. I do get really good reviews on my biopsy technique. Many people who come to me have had their biopsy done at a hospital before by an interventional radiologist. And I would tell you that interventional radiologists are really good at biopsying anything. I mean, lung masses, liver tumors, stuff in bones. I don't know how they do that so well. I just do the thyroid though, and I do it really well. The interventional radiologists have a lot of skills that I don't, but I happen to be really good at thyroid biopsies because it's all I do. So we anesthetize the tract so you don't feel the needle go in. We take 4 separate biopsies, 3 if you're not doing so well and you're having a little anxiety and want to stop. Usually all you'll feel is the needle kind of wiggling. I'll agitate the needle to try to pack it full of cells within the nodule. So the needle is hollow and it's got a core, and so we agitate it in and out. I use the capillary technique to draw cells out. And so if anything, people might feel their trachea or their thyroid wiggle a little bit while we do it. 3 aspirates are collected for cytology slides for the pathologist to review and physically look at the cells, and then a 4th is collected for the molecular profiling. We put a Band-Aid on at the end. I tell them they can take the Band-Aid off in 10 minutes. There's usually almost no swelling. An ice pack or a frozen bag of peas conforms really well to the neck if you're having any swelling. Tylenol and ibuprofen are perfectly sufficient for pain, and you shouldn't need more than that. It aches for 2 to 3 days because we do pass through a muscle, so you might feel it when you swallow a little bit. But there are no activity restrictions after. You can eat and drink whatever you want, and you can go work out at the gym if you're up for it. I do biopsies on blood thinners all the time. Studies have shown that people on Coumadin, Plavix, Xarelto all do fine, even anticoagulated. So the biopsies, I don't have to have you stop any anticoagulants for that. The results usually come back in 3 to 4 days. The results range from anywhere to a non-diagnostic result, meaning we don't know what it is still, that the nodule was stingy and didn't give enough cells up. It rates that 5% odds of a non-diagnostic result. And they range from non-diagnostic to benign, this gray area in between, and then cancer at the end. If the nodule comes back in the gray area where the pathologist says this biopsy result looks suspicious, I'm not quite sure what it is, it doesn't look benign, it doesn't necessarily look cancerous, then depending on how they term it, they use the Bethesda scoring system, which is a normalized and validated profile. Then depending on how they term it, we use the molecular profile next. And the molecular profile is where we test that sample for all these tumor marker genes and proteins to try to be a tie-breaking vote and say, yes, this is cancerous and it needs to come out, or no, it's not cancerous and you can leave it alone. That's the value of that molecular test that we have now that we didn't have 10 years ago. 10 years ago, if in an intermediate result, it was surgery for you, and we'll just hope and find out that everything's okay. And now so many patients were able to avoid surgery with molecular profiling. The molecular tests take about 2 more weeks to get the results back because they're not run until the first biopsy is done. Insurance covers a large portion of those, a very large portion, and then most of the ones that aren't are paid for on like a prorated scale base. So it's not going to be thousands of dollars. So we collect the sample and just store it in case we need it. And then I tell patients too that even when we're ordering that molecular test and we're waiting 2 more weeks, the odds are still heavily in their favor that they're non-cancerous. So when the biopsy shows atypia of undetermined significance, that's still only a 15% chance that this thyroid nodule is cancer and an 85% chance that it's not. I tell folks, yes, it's 2 more weeks, but rest easy. These are odds that we like still. And so we wait for the biopsy results on that.
Which of those biopsy results would then make a person a candidate for thyroid RFA?
So Bethesda 2 is benign. That means they found enough features and enough cells that they feel very comfortable saying that this is a non-cancerous result. Non-diagnostic results you'd want to repeat and ideally get a benign result. The results should always be interpreted, in my mind, also in light of the ultrasound appearance of the nodule. Some nodules, as Dr. Tufano pointed out, obviously look like cancer, and for whatever reason, you've got a benign result. And you have to take all that into consideration and say, in this particular uncommon case, I feel very uncomfortable leaving this nodule in place. But I would say that over the last, even just 2 or 3 years, I've only had 1 or 2 nodules where I really did not trust the biopsy results.
Really?
So it's quite common to trust your results. So another portion of what I'll tell people is that a benign finding is 97% accurate. So it means there's only a 3% chance that the pathologist is incorrect. And that is really about as good as it gets in medicine. That's really accurate. So when the biopsy says it's benign, we can really trust that a lot, and we can lean on that. And then we can sometimes do a second biopsy if the nodule's enlarging over the next couple of years or so. Even with a benign result, I typically do schedule my own follow-up ultrasounds in a year just to make sure that the nodule hasn't grown dramatically or changed. Industry-wide, that has proven to be a safe way to monitor nodules, to rule out this small chance of a false negative biopsy, meaning that your biopsy was benign, but actually it's cancerous and we just don't know it yet. And the way they found that is they took a number of patients, I forget the study, probably between 1,000 and 2,000 patients who ultimately had surgery, and they just looked back and said, was it cancerous or not? And they only found a cancer in 3% of those.
What about thyroid cysts?
Thyroid cysts are almost uniformly benign. Even in the American College of Radiology guidelines, typically pure cysts don't require any further follow-up. They're also not very amenable to tissue sampling because tissue sampling requires some cells, and you need a solid tumor to really collect cells. Cysts are full of fluid, which means nothing to a pathologist, nothing. So in order to get any tissue for them to say, I see what's going on, you have to have a solid component of that cyst or a mixed nodule. But a purely cystic lesion is not cancerous in almost any setting.
So would you say that performing surgery on a thyroid cyst is overkill, or is that ever needed?
It can be needed with caution in some situations. It is really a values-based decision. So it really comes down to, what does the patient want? What do I feel like I can offer? Can I meet their interests and needs? Can I set them at ease or not? So it's a little more nuanced because there are thyroid cysts that we remove. We do try to aspirate them and ablate them at times. There are some cysts that we remove because some people will hemorrhage into a cyst. So they have a stable cyst, and once or twice a year, it will just feel like it swells dramatically. And they'll call me and say, it's big today, it hurts. I'll bring them in and I'll aspirate it and I get blood out. And it only takes 1 or 2 times of that where people are like, get it out, I want it gone. So thyroid cysts, it would be nice to avoid surgically operating on those. I think those are great candidates for treatment by other methods. But there are situations where the value is there, that the patient says, like, I really do want it out. I feel it, it's growing, it swells periodically, and it scares me. And that's really valuable. They cause compressive symptoms a little less, because they're fluid filled, they don't tend to push quite as much. I had a really neat lady who, maybe in her late 80s or early 90s, who had a 13 centimeter cyst.
Oh my.
pushing her windpipe over into like a question mark. And she came to me because she thought she had allergies and had poorly controlled asthma and breathing problems for many years. And I thought, maybe you don't have asthma and breathing problems. Maybe you have compression from a really massive thyroid cyst. So we did a test run. I said, well, let's aspirate and draw the cyst out and see if you get any value from having the cyst on. And if you do, then we could talk about surgery to remove it. And I withdrew over 130 cc's of fluid.
Wow.
And she felt no different. So she had a grapefruit-sized cyst that caused no symptoms. So cysts can cause symptoms, but they can also be massive and not cause symptoms somehow. So we avoided surgery for her, thankfully.
So would that be something that, do you offer PEI in your practice?
I haven't routinely in the past, but it's something that we would do along with this. So we're set and prepared to do that as well.
Let's go back to the RFA discussion. You were talking about how you've got this very honed technique on your biopsies. So does that process lend itself to your RFA procedure technique as well?
I think absolutely it does. I perform about 250 biopsies a year, and the technique and everything is very refined, as you mentioned. And the same nuance that goes into having a good outcome and a painless biopsy and an accurate biopsy is applied to that. If you think about 250 biopsies a year and each biopsy actually being 4 aspirations, then over 1,000 times a year, I'm passing a needle under guidance into a nodule. There are some situations where the nodule is 5 millimeters, where I have someone with a nodule that we would not typically biopsy, but they also have breast cancer and they are intolerant of tumors anywhere. And then it shows up to be active on the PET scan, and now you have a 5 millimeter thyroid cancer that we find on the biopsy. So there are situations where I'm biopsying something really small, and that same technique is absolutely necessary, I believe, for complete ablation of thyroid nodules too.
So what is your procedure like when you do RFA? Tell us what the process is like for a patient.
So the process would be coming to our office. We do a video consult if the patient lived far away, and assess for risk factors and ability, review the ultrasound and see the amenability to RFA. And then our office is truly state-of-the-art, beautiful new clinic. There's about 20 ENT physicians who work here, so it's a fairly large place. And we have our own surgery center in the building, as well as multiple procedural suites. This we do in the procedure suite, so you come in and we put you in a gown for better access. We provide some numbing medicine in the appropriate areas, just like we do for a biopsy every day. And then the RFA event takes about 15 to 20 minutes to ablate the nodule.
Wow.
And then depending on the size, and then patients go home after, and we could do a video follow-up after or in-office follow-up after.
What about follow-up ultrasounds? How frequently do those take place after the procedure?
So most people do kind of 1, 3, and 6 months in a year, just for judging and determining completeness, monitoring resolution too. I think that will kind of go down as time goes on and more RFAs are being performed. I believe that kind of monitoring scale will become less frequent over time. People like to watch it shrink. So.
That's where I was going. Patients absolutely love to see what their results are after their procedure, because they're anxious to see that nodule shrink and go down. And one thing I tell them is, if you're waiting for an ultrasound and you can't wait any longer to see what your results are, take a tape measure and just measure your neck and see if you can see a smaller size in your neck, because that's actually what I experienced. My neck, since having RFA, I've had 2 RFAs, my neck has shrunk 3.5 inches.
No kidding.
Yeah.
Yeah. Fascinating.
And I've had a weight loss in that time period of since my first RFA to now, but that weight loss only contributed 1/4 of an inch. So
incredible. Yeah. Well, how good is that? That's fantastic. Yeah.
Yeah, I couldn't be more thrilled. You have 20 colleagues in your practice. Are any of them considering taking this on, or do they think that you are kind of off by yourself in another boat?
Well, so I think the ability to do RFA is all built on prior knowledge. So it's layering. You start math and simple stuff, and then do algebra, and then do calculus. And so I don't think you jump right into calculus. So I have 10 years of reviewing ultrasounds and doing my own and comparing them to radiologists and talking to them with endocrinologists, 10 years of doing biopsies of thyroid nodules and interpreting those, 10 years of biopsying lymph nodes and checking them for metastatic disease. And so the skill set that will be required to get there is a long process. No one else is looking into RFA. You technically could, right? But you always have to think about at what point are you actually providing really good value to patient. It's probably 6 months of doing thyroid ultrasounds before you're really doing it well enough to replace the radiologist and to provide the real value to the patient. The learning curve for RFA is absolutely higher, of course.
Yes, I think that, it's so interesting how different physician specialties have all of these skill sets that really help hone their skills towards RFA. And it sounds like, given your experience with ultrasound and biopsies, all being done in-house really does set you up for success here. So I'm so glad that you're doing this, and I hope that over time you can maybe bring some of your colleagues on board. But right now in Missouri, my understanding is that you're the only provider of RFA. Do you know of any other providers in your state?
I don't. I really don't. We're hopeful to be a landing spot for people who want some help and guidance. And even if that's just telehealth, talking and reviewing things, you know how much I value setting people at ease too. And so even if we just talk about your nodule and whether or not what you've been recommended is appropriate, I'm happy to do that as well.
Definitely. We see patients every day in our group and even on other social media groups. A lot of our patients have taken it upon themselves to help console other patients who are concerned about these things. Just yesterday, in fact, there was a patient in another Facebook group that I'm a member of who is so worried about her thyroid cyst becoming cancer later on. Wasn't just me, it was several other members of our group, reassuring her thyroid cysts are nearly always benign. This isn't likely to transform into cancer. It can be easily treated. She was already booked for surgery. So many patients were just saying, let's try to help you understand the facts and educate yourself before you go rushing into a surgery that, down the road you might regret. It's all about education. So.
I think so. And people want to make an informed decision. And so
exactly.
As surgeons, we talk about that all the time. What is informed consent? And I did a lot of research on that as a resident and trying to test patients' understanding of what you just said. And the studies show that in the office, when we talk, and I talk a lot, that patients retain, much less than we'd hoped. That they grasp onto one thing and hold on to another. But man, the second you bring up the possibility of cancer, it's just this wave of emotion, and it becomes very difficult to process everything that's being said. It truly is. And I found myself in situations like that as well, where someone said a whole lot to me, but I got stuck on this one thing and I forgot a bunch of stuff. Or I was so taken aback by it that I didn't ask all the questions I came to ask. I think just providing a space where we have plenty of time to talk about your condition, which is what I do, is very valuable to patients. And they frequently tell me, like, thanks for talking. I needed to hear all these things. Often in surgeons' offices, people are quite busy, and sometimes they're just, all they recall is that the surgeon said it needs to come out. And so I get second opinions for that as well, because people come and they say, he told me I needed surgery, or she told me I needed surgery, but I don't even know why. And that may or may not be totally accurate. They may have said everything, and maybe the patient's just overwhelmed, or maybe they were very busy and just said you need to have it out. Either way, there's value in going through that again with the patient.
Multiple opinions are good.
Yeah, that's right.
Helping you understand your perspective and the physician's perspective. Also, some physicians just don't even know about RFA or other alternatives to surgery. So it's always good to get multiple sets of eyes on you to know exactly, as you said, what to make an informed decision.
I tell people all the time, if you ever feel like you need a second opinion, go get it.
Yes.
And I tell them that when I can see that look in their eye that maybe they don't, maybe they're not sure with what I'm saying. I'll tell them, like, if you ever feel that way, you need to go get the second opinion, because when you come in on the day of surgery, the only thing that matters is that you are confident you're making the right choice.
Exactly.
That's it. And that means that you know everything that you're getting into, you know what you're going to get out of it, and that you trust the situation. And so for me, if I spend 45 minutes in a consult with a patient and they choose to have surgery with someone else, it doesn't bother me at all. I just need to know that they feel comfortable with what they're doing, because that day of surgery is the morning of surgery it's a very powerful connection. And it's very sacred to move into that space, and you have to have a lot of trust there.
You know, I think what you just said is going to resonate with patients tremendously, because so many patients feel like they're just sent to surgery like it's, you know, no big deal, and didn't really get the education that you're talking about offering to them. They feel helpless and lost. So having a physician-patient relationship that empowers the patient is truly vital to, you know, success long-term. And I think that patients are going to love hearing that. So thank you for sharing that. How can patients find you if they want to come visit you or set up a telehealth appointment?
Online, probably the easiest way to reach us. We have the ability to request an appointment online. It's Ascentist.com, ASCENTIST.com. You can request an appointment online, and a telehealth can be set up, or an in-office visit if you want to come in if you live in the area. We see people from the entire metro area and surrounding cities as well routinely.
Thank you so much for watching. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.